So let me introduce the moderator for our fourth lecture, Dr. Betty Ya-Wen Cho. Dr. Cho received her PhD degree from University of California, Berkeley. She is currently the first Vice President and Taiwan Regional Director at APAF. Dr. Cho's research interests cover health policy, global health, health security, evidence-based practice, and health adaptation to climate change. She has made significant contribution in shaping Taiwan's foreign aid and health policy. Since the start of ongoing COVID-19 pandemic, Dr. Cho has been invited to advise and offer policy recommendations in various public sectors. Now, without further ado, let me give you the host of our CCHP workshop and also the most charming moderator on earth, Dr. Betty Cho, Vice President 1 and Taiwan Regional Director of APAF, Principal Investigator, Institute of Population Health Sciences of NHRI. Let me give you Professor Cho. Please welcome Professor Cho to the stage.
Okay, good afternoon again. It's my great pleasure to introduce our fourth speaker today, Dr. Masamine Jimba. Jimba. Okay, Professor Emeritus from the University of Tokyo and the former president of APAF. He was made in Japan, but born for global health. I would like to say this. Dr. Jimba has worked on health projects in Asia, Africa, and Latin America for over 20 years and has held leadership positions in various health associations. He has published over 300 articles and has a PhD degree from Hamamatsu University School of Medicine in Japan. And his research interests include health promotion, global health, and human security. He has previously provided frontline medical humanitarian assistance with the Japan International Cooperation Agency, 就 JICA, 就是日本援助署, and served as a WHO health coordinator in the Gaza Strip, Middle East. 是这个到前线回来的人呐，做过前线、地线工作。Dr. Jimba is the top master in global health. I would like to say this, 全球卫生大师 and one of the global health workers and researchers I respect the most. 虽然爱开他玩笑，不过我很尊敬他。Dr. Jimba will bring a unique perspective to the important topic, moving towards the value-based public health in the era of AI. Let's give him a big hand.
Betty, thank you very much for your kind introduction. Usually I introduce myself with slides, but today I didn't, so I want to say something about global health. In Japan, we have a big chain of hospital, Tokuda Hospital. Torao Tokuda, he was a revolutionist in Japan to change the medical system. When he was a medical student in Osaka University, he was interested in global health, and he wanted to do something for Asia and Africa. But when he became fourth or fifth grade, he found there are many problems in Japan. Medical services are not given 24 hours a day. So he tried to make a new system to give health service 24 hours a day, 365 days, without any rest. And he created this system. He was very much hated by Japan Medical Association. He fought a lot. Then I had a question. So his way of thinking is Japan first, then go to other low-income countries. And if I follow his way of doing, when beyond Japan comes, Japan will continue to have some problems. So if I follow Japan first principle, I never be able to go to Asia, Africa, and other countries. So I decided not to go Japan first. Asia first, Africa first, Latin America first. But this way of thinking is very much criticized by Japanese people. We are paying tax for ourselves, not for others. So I try to take a balance in this. But this is my stance, why I'm so interested in global health. Today's topic, moving towards the value-based public health in the era of AI. I didn't know today's focus is lung cancer. So I did not include anything about lung cancer in my presentation, but I was a physician of lung cancer. My experience as a physician is just 3 years, but I used to treat lung cancer patients. And I know lung cancer is one of the most terrible cancer. For stomach, colon, you may not be able to drink or eat, but lung cancer, you cannot breathe easily. And this is really terrible things. So be afraid of lung cancer. Then let me go to the my presentation. This one. You may know this, EVM. I do not go into details. And this book is very famous. And the circuit, yeah, I think the original one was written by Sackett. And as this is the 5th edition, authors are different. But they said this is a book for clinicians. But EVM, they ultimately, its goal is to support the patients. And for this, they use not only scientific evidence, the clinician's experience is equally important. And you may be familiar with this hierarchy of evidence, starting from systematic review. And sometimes rumor is equally important at the SARS or H5N1 bird flu influenza. Rumor made a big contribution to take immediate action in Southeast Asia. But usually we think systematic reviews and meta-analysis are very, very important, and we believe in it. And for EVM, 60-30-10 challenge is still persisted. One article said 3 decades we have this problem. 60% of care on average is in line with evidence or consensus-based guidelines. 30, just some form of waste or low value. 10% is harm. And the EVM ecosystems. EVM is frequently used, but it contains some problems. Evaluation, some difficulties due to data silos. And implementation, difficult to incorporate clinical experience and patient values. Production, duplication. And then synthesis, slow and costly. These days, AI can make a big difference in evidence synthesis. It can detect research gaps and help better allocate research funds. And machine learning is more and more frequently used for the process of evidence synthesis. And living systematic reviews, this idea is coming up. And about this importance of living systematic reviews, one article shows almost 1 in 4 reviews not updated within 2 years from publication. So it contains conclusions inconsistent with new medical knowledge. This is a bit risky because the evidence changes quickly. The day after tomorrow, I'll tell it more details. In machine learning, it can expedite the process of evidence synthesis. And living systematic reviews are getting possible. I do not go into details about ChatGPT, but this is very much frequently used. This is one example made by University of Tokyo. In my university, diabetes professionals are very, very strong, politically strong within the University of Tokyo and in Japan. And they published this paper. Current machine learning algorithms have sufficient ability to help clinicians determine whether individuals will develop type 2 DM in the future. I think Taiwan is also equally very much advanced in the use of AI for diabetes control and treatment. And this is about a body weight. This learning mixture, heterogeneous mixture learning technology, I don't know what it is, but some researchers said this best machine learning model could successfully predict weight change over 3 years. So this technology is developing quite fast. And about this, we in Japan, I have been the chair of Global Health Committee in Japan Medical Association. In 1991, Nepal made a democratic revolution and became a democratic country. And in those days, ex-Prime Minister Hashimoto, he liked Nepal very much because Everest is there. And Prime Minister Hashimoto asked Japan Medical Association, do something for Nepal. Then Japan Medical Association started a Nepal project, community health and school health project. And I was involved with it for 5 years. Really, because of this, I became the chair of the newly made Global Health Committee. And last year was the year of Takemi Fellow 40th anniversary at Harvard. And the topic was digital health. We talked a lot about digital health. Then one of my friends called Dr. Yamamoto, who once made a lecture in Kaohsiung University, he said, evidence-based approach is already too old, getting too old. Meta-analysis, systematic reviews, AI can do a lot. Maybe AI can do much better than we do. And if the highest level of hierarchy of evidence can be done by AI, what will be the role of human, us? Then he introduced the idea of value-based medicine. And value might be affected by culture, context, and other unique factors, maybe religion, which AI is less useful. So now we live in the era of AI, but we have to go beyond AI. And to this, we have to go beyond the evidence-based approach. That's value-based approach. And I found this book is already published, From Evidence-Based to Value-Based Medicine, 2005. But in this book, they say not only measuring length of life, mortality or morbidity, measuring quality of life as an outcome is important. Now for us it's not really new. We have lots of evidence about quality of life, health-related quality of life, maybe affected by this book. Then this book has a much more influential Michael Porter introduced the idea of value-based medicine, but for him, value means health outcomes achieved per unit cost expended. So it's all, I think he's very much money-oriented way of thinking. Value means money. How you can achieve better with limited use of money. Then value-based approach appear in many academic articles. Value-based care, value-based medicine, value-based surgery, value-based plastic surgery, value-based genomics, value-based public health. Value-based global health, I haven't seen it, but value-based design global health is already published. So today I want to focus on value-based healthcare and value-based public health. What is value in value-based healthcare? I think this is done by European Commission. They divided value into four: allocative value, technical value, personal value, which we are very much familiar with, and societal value. Allocative value means equitable distribution of resources across all patients groups. Technical value is very close to Michael Porter's evidence-based, value-based medicine, achievement of best possible outcomes with available resources. Then personal value, patients' satisfaction and these things, and societal value. I go for it after later. And how to use value-based healthcare? There are some guidelines. Reallocate resources, fighting corruption, increase public value in biomedical and health research. Then policies and incentives. Then how we can go from value-based medicine or value-based healthcare to value-based public health. And I didn't know this term, value-based public health. When I heard the term value-based medicine, in the history of value-based public health, I had an ambition. I will be the first person who proposed value-based public health, but the UK already did it. Wales. So these are the value-based healthcare and societal value. And value-based public health, by saying it, they say this societal value or social value is very important. This means contribution of healthcare to social participation and connectedness. Why social value is important? Need for expanding the traditional value for money approach. Value does not always mean only money. Value means much broad. And invest in people's well-being is important. And the COVID-19 period showed us the investment in public health is quite limited. So it's time for transformative recovery and building sustainable, inclusive systems. And the Wales public health the WHO's collaborating center, they showed this concept, social return on investment. This is a new or novel outcome-based measurement tool that can support organizations to understand, capture, quantify the social, environmental, and economic value they are creating. So quantify is the key, and I don't know how to quantify. Maybe health economist is good at it. And they showed some examples. Investment in sports and leisure facilities in England. With £1 investment, they say 1.2 or 3.4 pound return comes. I don't know how they calculate it. However, I found this is interesting. They use outcome, improved well-being, improved social capital. Can we measure these things when we conduct some intervention for disease control? But they look at this. This is social return. And the last time I introduced this, active transportation planning, so I do not go into details. But in the city of Ottawa, they looked at the activities of transportation and division. And by increasing walking and cycling instead of using automobile, they said this behavior change can prevent as many as 1,220 incident cases of diabetes. So this came from transportation section, and the health sector tried to work together with them. Then last year I went to Iran, and I learned sports everywhere initiative in Taiwan. And I thought this is quite similar to Canada's case. I think this is value-based public health. And the UK is always, I think, clever, take a good initiative, make a good umbrella to cover different activities. And we didn't know this is value-based public health. But this can be part of value-based public health because by taking this sports everywhere initiative, you try to improve not only health, but well-being. And in Japan also, something similar is taking place. Have you ever heard of Chokozap? This is a sports center. The monthly membership cost is 3,000 yen. And you can go to the gym 24 hours, anytime. And in the beginning, it was only the sports center. Now you can try karaoke. You can try nailing for women. A lot of pilot programs are conducted. It started with sports, but it spread to other well-being issues. So it came from private sector, but it's very interesting. I think the branch is also available in Taiwan. Then investment in social prescribing. Are you doing social prescribing in Taiwan? Is it getting popular? Not yet. In Singapore, you have already done. It started with the UK. Again, they started it as a new initiative, but in Japan already done without knowing it's social prescribing. So they are again measuring learning through volunteering, improved educational outcomes. These things usually we do not measure after health interventions. But they measure these things as outcome, and they change this to money. This is the brief explanation about social prescribing. Social prescribing means refer patients to some community activities. And I have many physicians, and 95% of my classmates become clinicians. And they are suffering from the patients. Diabetes patients, hypertension patients, they treat, but they come back because they do nothing in the community. They never change behavior. That's why they come back. And social prescribing can solve this problem. And if you are interested in social prescribing, you may watch this video. I'll give you the YouTube website later. Why social prescribing? High prevalence of NCDs. Now 74% of deaths in the world caused by NCDs. In 2048, WHO's 100th anniversary year, 86% will die due to NCDs. So it's getting higher and higher. And we have no modifiable social determinants of health. And we now have evidence about cost effectiveness, sustainability, and mental health benefit is much bigger by social prescribing. It facilitates behavior change and builds up local communities. And this is a system. Patient go to primary healthcare doctors, then they give information to link worker. Link workers are the key players of social prescribing. Then link workers introduce some activities to community sector. This is social prescribing services. Education groups, arts, volunteering, adult learning, cycling, dance classes, these things are all social prescribing contents. And surprisingly, when I visited digital health exhibition in Taiwan several years ago, I saw this screen on the computer. And older people can push the button of these activities, and they can be connected to these activities. So I found, and in Japan we have at least 2 books about social prescribing. This is Chinese characters. In UK, this is a system. Link workers are professionally trained now, and they got salary. In Japan, the doctor who wrote this book said, we do not make it a system. We have a culture of social prescribing using community volunteers or public health nurses. And now Japan is doing a pilot program about social prescribing. Then the problem is whether we should give money to the volunteers or extra money for the public health nurses. So we still need how to make it more functional. But we are pushing this. Then Taiwan, what is the digital? But you may think about the how you should go ahead with social prescribing. And Spain, electronic medical records, electric prescription, and they are measuring something we usually do not measure. So this is the cycle of social value or value-based public health. And what is social value? Quantification And this needs some special support from a health economist. The quantification of the relative importance that people place on the changes they experience in their lives. And it is increasingly important to help deliver the most value for money. So I have been telling value is not only money, but by changing the several components to money, it is more persuading to the government or local government. Measuring social value can enable public health organizations, particularly about investment in high value upstream interventions. I usually use this photo, and this is related to the question to the Korean professor. So even if you cannot become totally healthy, she may get lung cancer. By rehabilitation, she may be able to up to come here. But with this health, she can get quality of life, well-being, happy. Ottawa Charter said, health is not an objective of life. It is a resource for everyday life. So the last 10 years, the gap between health expectancy and healthy life expectancy, the last 10 years, we can use this. It is a resource for everyday life. And then in the health promotion field, they say lifestyle drift is dangerous. We talked a lot about the importance of lifestyle, but by focusing too much on lifestyle, we tend to forget about upstream. This is average, you may not be able to see the small number, but average life expectancy by prefecture in Japan. And I want to focus on Okinawa. 1965, Okinawa was occupied by the United States. 1972, Okinawa became part of Japan. So 1965, there's no data in Okinawa. And Okinawa used to be the top prefecture of achieving best average life expectancy. For men, it's getting worse and worse. For women, it's comparatively good. Why Okinawa's men perform so bad? After US occupation finished, US fast food industry occupied Okinawa's food style. McDonald's, Kentucky Fried, Shakey's. These things most common in Okinawa. McDonald's is also very much common in Okinawa. In this way, upstream did not allow behavior change well. So I do not go into details, but we have to think about upstream, but to what level? And this, now you have plastic, but this is a problem now. If you are interested in about plastic pollution, come to this place the day after tomorrow. I talk about it. So environmental pollutants is getting a very, very big problem, which affects inner cities too. So as time is already over, I stop here. Thank you very much.
Because time is limited, we can open the floor for only one question. And before the question is raising, I would like to apologize to Dr. Jimba because we pushed him too much. Actually, we invited him to come for 3 days. This is just the first talk, and we have another 2 talks in 2 different topics within 3 days. So the secretariat may confuse by the, yeah, anyway. So whoever get the hard copy, we actually put the his handouts for
Thursday.
Wednesday, or for the Thursday, for Father's Day. Yeah, happy Father's Day. But if you scan the QR code, you can get the correct PPT, no problem. Okay. Okay. Any question? Oh, Dr. YY.
Thank you very much, Professor Jimba, for your excellent talk. On the point, it's actually more a comment than a question, but I think on the point that you introduced about value-based public health, I was wondering whether you should also, do you think that there is also an important word of caution there? Because I believe when we start thinking about value-based public health, quite a bit is linked to rigorous monitoring and evaluation to determine whether even social prescribing works. Because there could be social prescribing activities which are just activating those that are already mobile or activated. So putting in more resources to get people to be active in the community when they are already active in the community, it actually is a waste of public money. And I think that that's where even social prescribing under the framework of social return on investment, that return on investment must be calculated on the basis of not just activating those group of people that are already moving and interested, but including activating what we would consider the unactivated. Because what I would see in any country is that regardless of whether you are introducing any public health programs on vaccination, on physical activity, or nutrition, there will be generally 3 groups of people. The first group of people will be the activated. They are the people you don't need to give them more information or resources. Generally, they will do the right thing. You have the last group, the third group, that it's no matter how much money you throw at them, they will never do the right thing. But it's the second group of people that are liable to be nudged, where if you provide them with information, you provide them with incentives, they will behave in a way moving towards the first group. And actually, the value of many public health initiatives focuses on trying to target the second group. And I think even social prescribing, there is a message there that we are still trying to focus much more on the second group. Because the first group, in a way, because we don't need to waste more public money, they will be doing the right thing. So that's why even social prescribing, I believe that when it comes under the framework of value-based public health, we need to measure accurately to determine whether it is still effective and cost-effective. Thank you.
Thank you very much. I think focusing on the second group is really good, but at the same time, we are living in the age of SDGs, leaving no one left behind. And leave no one behind means look at the third group. And the third group are the group which needs more investment. And it was proven during the COVID-19. In Singapore, the third group became the hotspot of new cases of COVID-19. And these third groups are the groups, we may call it vulnerable population. And for the vulnerable population, we need to take 2 important approaches: intersectoral approach and participatory approach. Intersectoral approach is important because these third group are not only affected by health problems, they are affected by jobs, lack of education, lack of human support. And they are not very much interested in health, although they are suffering from health issues. They are suffering from issues which affect their life, their family's life. So without supporting these aspects, very difficult to help them. And participation, they look very weak, vulnerable, but they can do something. And we can find some positive deviance, which I like very much. And we did this for the homeless in Shinjuku, Japan. Homeless people did not want to come to the clinics to treat TB, tuberculosis. But NGOs worked with them. They identified the problems, and then those helped by NGOs. Homeless people became the teacher of other homeless to support. So in this way, there are some ways to help the third group, and this might be important, at least until 2030. And I don't know what comes after 2030. Thank you very much for your question.
Okay, let's give Dr. Jimba another big hand. Thank you.